welcome to the CLDF podcast. My name is Fred Gordon, and I'm the medical director of liver transplantation and the chief of abdominal transplant medicine at Tufts Medical Center in Boston. I'm here with
Valentina Medici. I'm a professor at University of California, Davis, when I'm also the director of the Wilson Disease Center of Excellence.
So today we're going to talk about Wilson's disease. So who do we suspect has Wilson's disease?
Well, so that it's definitely a challenging situation or a disease sometimes to rule out or rule in, really. And what I would say is that any unexpected elevation or unexplained elevation of liver enzymes or any really degree of or severity of liver disease from, again, just a mild elevation of liver enzymes to hepatic steatosis, cirrhosis, or acute liver failure, that it's otherwise unexplained. In really any age of patients, we tend to associate with younger patients, usually younger than 50, but really older ages should not completely rule out or be an exclusion for Wilson disease. Also, of course, any neurological manifestations, like movement disorders or neuropsychiatric manifestations, that it's unexplained Parkinson-like symptoms or movement disorders that are in a patient that is younger than 40-year-old will be very likely to be Parkinson, so Wilson disease should be suspected.
And of course, all people who have family members who have documented Wilson's, those people are suspect as well. So it's really, I think, almost anybody who has chronically elevated liver enzymes. So it's a lot of people that we're going to see in our clinics and even a lot of people that we consult in the hospital.
Completely agree. Yeah. So that, I think, leads us to the laboratory assessment and how we proceed after we have the first clinical suspicion of Wilson disease. So how do you think we navigate this very frequent gray zone of mildly or borderline reduced ceruloplasmin level, for example?
Yeah. So one of the early tests that we're going to do, obviously, is a ceruloplasmin. That seems to be part of a chronic liver disease evaluation for everybody. And also, don't forget, I think we should mention that people with MASH and autoimmune hepatitis, those are great mimickers. Wilson's is a great mimicker of those. So especially those patients need a ceruloplasmin. The problem with interpreting a ceruloplasmin is it's a protein that's made by the liver. And so if these people have chronic liver disease, especially if it's more advanced, they may have a low ceruloplasmin just because they're not making proteins properly. It's also an acute phase reactant, so that can also elevate the ceruloplasmin. But I think most of the time in patients with real Wilson's disease, you're going to see a low level.
Yeah, absolutely. Yeah, when patients with clear diagnosis, which is about 50-60% of patients with Wilson disease will really fit like the textbook criteria. So the ceruloplasmin will be below 5. And then we do have the remaining 30% where you have these ceruloplasmin with levels between 15, 16, 17. And even with the established diagnosis of Wilson disease, sometimes you see the level fluctuate over time and sometimes even go above 20 for various reasons, including ongoing inflammation.
Yeah, so the next step, I think, is always to get the 24-hour urine collection. And that's often difficult because patients forget. You give them the jug to take home and they don't do it properly. And so making sure that you have a good full collection by looking at the creatinine production also is very important.
Other tests that we use would be, well, of course, the liver biopsy. That will definitely help. Also an invasive procedure, but still very significant in Wilson disease will have elevated hepatic copper concentration.
Yeah, I struggle with that a little bit because honestly, most of the time we're actually ruling out Wilson's more commonly than ruling in since Wilson's is so rare. And so you love to avoid doing the biopsy. So I think interpreting the ceruloplasmin with the 24-hour urine collection hopefully will take out most of the people, and then your choice to do biopsy is in a smaller group.
Absolutely.
If in the situation where, because we see this, I think, in inpatients a lot, where you have the ceruloplasmin that's just borderline low, not less than 5, and then you do a 24-hour collection, and you hope that because they're hospitalized, they did it correctly. But you see these levels of urinary copper that are, not low. They're not necessarily diagnostic greater than 100, but they're between that 50, 60, 70 territory, and there could be a variety of reasons for that while they're hospitalized. That's the difficult population. And similarly as an outpatient, but I think it's more commonly seen in the inpatient setting.
Completely agree. When the patients are particularly sick, that's why they're hospitalized. And then we tend to do, because sometimes they typically will be the youngish patients where we want to make sure that, we are attributing this to decompensated alcohol, for example, associated liver disease. We're not completely sure, and then we want to rule out other things. So,
yeah, one of the things that I know I and my colleagues often forget is that there's a very simple test. It's just hard to get in because ophthalmologists are busy. But ordering a test for KF rings, Kaiser-Fleischer rings, is critically important because most people, I think, will have them.
Absolutely, yeah. And that is an interesting test because actually it allows us potentially to follow up over time the response to treatment when the diagnosis is established, yeah.
Yeah, so I kind of use the combination of the ceruloplasmin, the urine copper, and the presence or absence of KF rings to hopefully give me a stronger base to say yes or no to the diagnosis of Wilson's disease. And that's the way I've tried to avoid biopsying most people.
Yeah. And I think that leads us to the next level test, which could be the use of a genetic test.
Yeah, genetic testing, unfortunately, the turnaround time, at least at my institution, is pretty long. So oftentimes you need to try and make some decisions before that. But the genetic testing is for these people that you just can't really tell whether they're ruling in or ruling out the diagnosis.
Yeah, through the fact that, again, if you find the mutations, well, then on the 2 chromosomes, then you have the diagnosis. But if you don't, or if you find that the patient is potentially heterozygous, then you can still not completely rule out Wilson disease, especially when you still have the clinical suspicion and the copper metabolism parameters are potentially, borderline or indicating alteration in copper metabolism. But that genetic test can be particularly helpful when you have family history of Wilson disease. So, for example, when there is the index case, when you establish diagnosis of Wilson disease, then you can use a genetic test in various ways. So if you know the variants already, if you are in that lucky positions where you know the variants and you know that disease-causing mutations, then you can look for those specific mutations and sequence the exons for those mutations in family members, particularly, of course, siblings. Those will be the first to be tested. But we are also interested in the offsprings. Eventually, offspring will be, we can generally use a very reassuring language with the patients because, of course, offspring will have a very low probability, like lower than 5% to have Wilson disease. But still, it's a devastating disease if it goes undiagnosed. And so you want patients nowadays will want to know if their children have the mutation.
Yeah, it's autosomal recessive, and so you can always reach back and use your old high school fruit fly genetics models, the 2x2 box to assess the risk of having it as a child or as a sibling. Let's talk for a second about the unknown mutations, the ones that aren't clearly associated. What do we do with those?
All right. What do we do? So that it's, there is always the use of, consult your geneticist in your institution. Make sure you use those resources. And then I would say always work on the, clinical correlations. If you have the clinical suspicion and mutations are not necessarily supporting those, you still have, I think, to believe in your trust, your clinical suspicion and monitor or eventually consider treatment. Yeah.
That's also the place where I if I haven't already done a biopsy, that's where the biopsy I think is very helpful, because if you have a low copper content in the biopsy, at that point, I think you can just sort of say we're done. If you have a high copper content, then you're ruled in. And again, you may find yourself back in the gray zone, in which case, following the ceruloplasmin, following the urine copper, I think those ultimately can lead you to the diagnosis. So thank you for listening. Please subscribe. And for more content like this, please visit the CLDF website at chronicliverdisease.org.